we'll start this session. The session name is the Symposium on Early Reproduction Syndrome. We have three distinguished speakers from Europe and Thailand. The first speaker is Professor Pedro Brugada. He's talking about the Brugada syndrome, then and now. Pedro, please.
Good morning, Mr. Chairman, ladies and gentlemen. I'm really pleased to be here, and I really thank you for attending this meeting in the last day, which is always a problem. Now, my task during the next 21 minutes is to tell you a little bit on how Brugada syndrome has changed over these years. And as you can see, the topic I was given to me was to talk to you about then, the past, and now, the present. But of course, I will talk a little bit, and it's not in the title, about also the future, particularly what worries me about the future knowledge and future research on this syndrome. As you know very well, everything started in 1986, at the time that the Wall of Berlin was still there, and this Polish guy, Lech, actually at 3 years of age, came to the University of Maastricht, where I was working at that time, with his father because of repeated cardiac arrest of unknown origin. Actually, he had a family history of a sister that had died suddenly at age 3, and later on we discovered that the father also was a carrier of the same electrocardiogram, which you can see here, an electrocardiogram which had not been previously described in the literature in this sense. And as you can see, this electrocardiogram at 50 millimeters paper speed, be careful, this is double the normal speed. You see that there is a prolongation of the PR interval. These are leads V1, V2, and V3. There is what looks like a right bundle branch lock, a wide QRS complex. You see repolarization abnormalities, the typical ST elevation here, negative T wave. And actually, if you look carefully, we didn't see that at that time, and you look at lead V3 magnified, you see that there is also actually fragmentation of the QRS complex in this electrocardiogram. So he got a very special electrocardiogram. After seeing him and seeing the electrocardiograms of the sister, I collected data on 2 additional patients, and finally, we reported these 4 patients as an abstract in 1991 in the North American Society of Pacing and Electrophysiology. We were happy to collect 4 additional patients, all of them with the same characteristics, and actually, we published this paper in 1992, not after a lot of difficulties. It was very difficult to publish this paper, where there were 8 patients with all of them exactly the same pattern, the clinical electrocardiographic pattern of what looks like a right bundle branch lock with persistent ST segment elevation in the right precordial leads, and all of them had been resuscitated of sudden cardiac death. So this syndrome, actually, at the very beginning, was a very homogeneous clinical picture with aborted sudden cardiac death and a typical electrocardiogram, which included conduction disturbances and repolarization abnormalities in all the patients. Now, I'm going to show you how this has changed in these 33 years, both clinically and electrocardiographically. One important thing I want to make, again, the point of it, is that you diagnose Brugada syndrome only if you have excluded other causes of ST segment elevation. We know all very clearly that if some patient presents with chest pain and has an acute anterior wall myocardial infarction, you will see ST segment elevation. This is anterior wall myocardial infarction, not Brugada syndrome. If a patient has an acute myocarditis, this is myocarditis. This is not Brugada syndrome. And if a patient has severe hyperkalemia, this is hyperkalemia and not Brugada syndrome. But I'll come back later to the point of what we call the phenocopies, electrocardiograms that can be very confusing in terms of the diagnosis. In any case, these patients, all of them have a structurally normal heart. One little point, in the present day, you can see a lot of the reports suggesting that there might be abnormal motion abnormalities in the right ventricular outflow tract of Brugada syndrome patients. Of course they are, because there is abnormal conduction in the outflow tract of the right ventricle, and you can compare this to asynchrony of the left ventricle in left bundle branch block. Asynchrony in left bundle branch block is not a cardiomyopathy, it's simply an electrical problem. And I believe myself, and I'll show you evidence for that, that the so-called cardiomyopathy in Brugada syndrome is only an electrical problem, and I'll show you that this can be corrected by electrical stimulation of the right ventricular outflow tract, showing that this is not a cardiomyopathy, but an electrical problem. Now, the electrocardiogram of Brugada syndrome has shown us in these 30 plus years that not only the ST segment elevation, but many other things can be present. And you see here, at one side we have the conduction defects, and at the other side we have the repolarization abnormalities. And there is a lot, of course, of overlap. And patients can manifest with one or multiple of these electrocardiograms. So the syndrome, as it was initially defined, was because of the ST segment elevation on the ECG. But this is only one of the manifestations, because you can have J-wave accentuation, you can have QT prolongation, QT shortening, and of course the ventricular arrhythmias as manifestation of the repolarization abnormality. But on the other side, the conduction defects, the depolarization abnormalities, can give you an abnormal P-wave duration, prolongation of the PR interval, prolongation of the QRS complex with or without right bundle branch block or left anterior or posterior hemiblock. Sinus node dysfunction, extremely important from the prognostic point of view, particularly in syndrome. Atrial arrhythmias like atrial tachycardia, flutter, and fibrillation. Late potentials as a marker of a slow conduction, and as I show you, fragmentation of the QRS complex. So the whole thing is much more complex than only the ST segment elevation. But still, for the diagnosis of Brugada syndrome, you need a type 1 electrocardiogram, this one, with the ST segment elevation. You know that the electrocardiogram changes over time. This is a very dynamic electrocardiogram, and some people may show what is called the type 2 electrocardiogram, or what we call the type 3 electrocardiogram, the difference being that there is here no convex XT elevation, and actually have the saddleback pattern here without a ST elevation, and here actually with a little bit of a ST segment elevation. Now, note please in these two electrocardiograms that the R prima that you see here is not the same R prima that you see in a normal young individual with incomplete right bundle branch block. I'll come back to this point. This R prima is very wide, has a very wide base. It's not just a sharp R prima, it's a very wide R prima. This is also a possible marker of Brugada syndrome. But this one, type 1 electrocardiogram, that's the one that actually you need for the diagnosis. Important, anytime that you see these repolarization abnormalities, be aware that whatever the cause, whether this is Brugada syndrome, acute ischemia, myocarditis, or electrolyte abnormalities, this means, this repolarization abnormality, that the heart is in severe electrical trouble. This is a possible marker of these arrhythmias, which are ventricular fibrillation and polymorphic ventricular tachycardia that can cause sudden cardiac death. Now, let me show you how things have changed in terms of the title of that paper that we published. Right bundle branch block. Well, in some cases, we have beautiful right bundle branch block. Look at this electrocardiogram with an S wave in lead 1, with an R prime in AVR, with a R prime in V1 and in V6 with a wide QRS complex and the typical ST segment elevation. But look at this electrocardiogram here. There is the repolarization abnormality, but you have not a single marker like here of conduction abnormalities. Now, nowadays we know better. This is fitting with a nice mutation in the sodium channel that results in depolarization abnormalities, PR prolongation, wide QRS complex, right bundle branch block, and at the same time, repolarization abnormalities, the ST segment elevation. Well, here you have an electrocardiogram that is much more compatible with a pure repolarization problem, like can happen in mutations in the potassium channel or in the calcium channel. So we are starting to see differences, which might also tell us that this is not one single disease, but many diseases with the same phase, like in the long QT syndrome. Now, do you know that the electrocardiogram is extremely dynamic, and this is very important because it makes very difficult the diagnosis if you do not think of Brugada syndrome. And what I'm going to show you is simply an electrocardiogram of a Japanese patient who was resuscitated in Germany. Again, the paper speed here is 50 millimeters per second. That's why it looks a little bit funny. But you see, when the patient enters in February 5th in the hospital after resuscitation, has the typical features of Brugada syndrome, and the next days, you can see here, the electrocardiogram looks much more normal. It's not normal. Look at this R prime here. If you look at this angle, which is the beta angle, actually, this is too wide. This is a J wave. This is a repolarization abnormality, or maybe depolarization. We don't know very well. But this is not just an incomplete right bundle branch. In any case, here, it's very difficult to make the diagnosis. You need this electrocardiogram for the diagnosis of Brugada syndrome. Now, what we do to unmask this electrocardiogram, you know it very well. We use ashmalin infusion, and we use the high precordial leads to actually recognize that the patient has Brugada syndrome. And here you see an example of someone with repetitive syncope of a known cause, family history of sudden death at young age, and in whom the administration of ashmalin unmasks this electrocardiogram typical of Brugada syndrome. And you see that ashmalin, because of the short half-life, the electrocardiogram recovers very fast. You can use flecainide, yes, but there are some studies suggesting that the sensitivity is less than actually intravenous ashmalin. Now, we know already for a long time, because these electrocardiograms are very old ones, that the response to ashmalin in some way is related to the degree is related to how bad actually the disease is in some families. To start with, if you look in children, we have seen that children can have very abnormal responses. Here you see mainly a response in terms of conduction abnormalities, wide QRS complex, right bundle branch block appearing after ashmalin, alternance of the T wave. So this is a heart that is very sick, so sick that the patient was actually here in hemodynamic compromise, and we had to massage this patient. Or this young girl of 6 years of age with also severe family of sudden death, where actually goes into ventricular fibrillation during ashmalin. This is related to the severity of the disease. And we have seen also that once you have one family member that develops ventricular fibrillation with ashmalin, be aware that other members of the same family might also develop this ventricular fibrillation. Now, I'm going to jump a little bit about this because of the time concerns. One thing that is important is related to actually exercise, that not all patients with Brugada syndrome behave in the same way. And you see here an exercise test. This is at rest, that is during maximal exercise, and this is during the recovery, where you see the appearance of a ST segment elevation after exercise. During exercise, that's not the problem. Patients with Brugada syndrome actually can develop ventricular tachycardia after exercise, not during exercise. And this is related to, of course, the effects of adrenaline and the disappearance of the effects of adrenaline post-exercise. Just be aware that in patients with Brugada syndrome, we are actually recommending at the present time, particularly in young individuals, if they want to undergo sport activities, to always have an exercise test to actually avoid these problems. Now, how has the electrocardiogram changed in terms of the repolarization abnormalities? Well, look, you have seen this electrocardiogram, but probably you didn't look at the fact that in AVL, we have also ST segment elevation. And look at this patient also with Brugada syndrome. This is now AVL. Here you see also elevation of the ST segment, as you can see in AVL. Does that mean that there is affectation of the left ventricle? We don't know. at the present time. But I'm just showing you that. Look at this ST elevation in the inferior leads, together with the ST segment elevation in the precordial leads. Does that mean that the inferior part of the right or the left ventricle is also affected in this family? Probably could be. Look at this one. Instead of showing ST elevation, shows ST depression in the precordial leads and ST segment elevation with alternance in the inferior leads. So the electrocardiogram of Brugada syndrome is not only variable, but depending upon the families and depending upon the individuals, might show different problems. Now, the phenocopies. You see, in this case, it was very easy. This is an 85-year-old lady that had an electrocardiogram suggestive of Brugada syndrome. We perform an MRI and we find a thymoma. We explanted this thymoma, and actually this happened in Madrid by Dr. Jerónimo Ferrer, who is the cardiologist of this patient. The electrocardiogram normalized. There was no family history of sudden death, nothing, and actually the patient had a negative Ashmelin test afterwards. So this is probably just pure compression of the outflow tract and a slow conduction caused by the tumor. This looks the same. This is a patient with severe pectus excavatum. And you see here his electrocardiogram shows conduction disturbance in the right ventricle, but actually Ashmelin test was positive. And we thought, oh, this is going to be the pectus excavatum. Unfortunately, and fortunately, that patient, actually, we did implant an ICD because of the family history of sudden death, because he had also syncope, and we didn't trust the whole thing. And it took 8 years before he presented the next syncopal episode, which turned out to be ventricular fibrillation terminated by the ICD. So be aware of phenocopies. You can have 2 diseases at the same time. You can break your right leg today, and tomorrow you can break your left leg. So don't forget that you can have sometimes phenocopies, but other time, be careful, that can be something completely different. The same holds, for instance, for diseases, skeletal muscle diseases. We have seen an association between Brugada syndrome and skeletal muscle disease, indeed. And look at this is that myotonic dystrophy type 1. And actually, if you look now at these patients, you will see that mutations in the sodium channel that cause the myotonic dystrophy can also be present in the heart, because the sodium channel of the skeletal muscle is also present in the heart, and mutations in the cardiac sodium channel can be also present in the skeletal muscle, because the cardiac sodium channel is also present in the skeletal muscle. It's not in little boxes like we classify everything. It's much more complex medicine. Now, very important, I want to tell you one thing that we have learned about the third factor, sudden death in Brugada syndrome. We always think of ventricular fibrillation. I'm sorry, this is not the only cause of sudden death in Brugada syndrome. Asystole can also cause sudden cardiac death. And actually, what these patients may die is of one non-paceable asystole. What I mean by that, these are the patients that we have seen dying like this. They all had a defibrillator implanted, and we saw that there was no capture whatsoever of the heart by the defibrillator at the time that these patients died. So non-paceable asystole is also a cause of sudden death in Brugada syndrome. And unfortunately, we don't know nowadays what we can do to prevent this sudden death. To be honest, I really don't know. And I'm very worried when we see that patients with Brugada syndrome start to have more and more backup ventricular pacing, because might be a harbinger of a future event like this asystole. Now, one word about what some people call overlapping syndromes. I just call it discordant family patterns or family syndromes. For instance, this family coming from actually Amsterdam, where they had long QT syndrome, the family members that were female, and with the same mutations, male had Brugada syndrome without QT prolongation. Or this family coming from Nantes in France, from Dr. Denis Skanda, where the males had Brugada syndrome without conduction abnormalities, and females conduction abnormalities without ST segment elevation. So you see how much we still have to learn about this disease to explain these different manifestations in the same family with the same mutations. Atrial arrhythmias have become extremely important in Brugada syndrome, not only because they cause palpitations, they can cause heart failure, and of course they can cause transient ischemic attacks, but because actually we have seen that all the parameters that we use in a normal patient without Brugada syndrome and atrial fibrillation do not hold for Brugada syndrome. If you look at the incidence of transient ischemic attacks in Brugada syndrome, you cannot explain it at all because of the Schatz score. The Schatz score of these individuals are 0 and 1 when they are a female, because these are young individuals without structural heart disease or any problem. However, the incidence of transient ischemic attacks is extremely high. Why? We don't know. Some people suggest that actually the coagulating factors at the level of channels also are altered in Brugada syndrome, and that might be the cause of sudden death. And look at this, sometimes how medicine can be funny. This is a very old electrocardiogram of a young individual, in this case now with atrial flutter, and actually after cardioversion shows this typical type 1 Brugada pattern. We would have thought in the past that this was simply repolarization abnormality caused by the DC shock. No, this is simply a patient who has Brugada syndrome, and the DC shock unmasks this. I'm going to show you this fragmentation of the QRS complex, just to show you how important it is from the prognostic point of view. You see it here. These are studies coming from Dr. Oe from Japan, showing that the fragmented QRS complex is a marker of poor outcome. And I'm going just to show you actually what we are doing nowadays to risk stratify our patients with Brugada syndrome. And we are doing this with this score that has been published in the European Heart Journal in 2017 by Dr. Sieria from our group. And we found 6 factors actually that are important in terms of prognosis. And the more points you get, the worse the prognosis. Spontaneous type 1 ECG, family history of sudden deaths at early age, inducibility at program electrical stimulation, a history of syncope, and this is yes or no. Forget about trying to know whether this is vasovagal or so, all this, yes or no. We do not ask any other question. Sinus node dysfunction and resuscitated sudden cardiac death. And you can see here that the more points you get, the worse is the prognosis, because this is the survival without cardiac arrest, sudden death, or appropriate ICD shock in 400 individuals with a mean age of 40 years here. Here, 10 years later, this is a very long-term follow-up, 50 years of age. And you see that even the 0-point population with Brugada syndrome has a 3% mortality at 10 years. And this is 40 years of age, this population. So this is 300 times more sudden death mortality than a normal individual of 40 years of age without Brugada syndrome. Then you make your own conclusions whether you protect or not the patient with the ICD together with the patient, because we always respect the desire of the patients. This is a study by Papadakis about what is this Brugada syndrome. Is that a rare disease? Going to go directly to the conclusions. Basically what they did, they tested 911 relatives of 303 patients with sudden death with negative autopsy, and a lot of these people with so-called an expert autopsy. And they tested the whole family with Ashmalin and other tests, and they come out with actually 28% of these families having a diagnosis of Brugada syndrome. And as you can see, that was far ahead of diagnoses like long QT, CPVT, conduction disease, or other overlap syndromes. So the most important cause of sudden death was Brugada syndrome, as shown in this slide graphically, for these families where a diagnosis had not been made even after autopsy of the disease. I'm going to finish by showing you some future perspectives in 1 minute. Basically, you know that at Nademané started the first epicardial ablations in Brugada syndrome, showing that there was abnormal conduction and eliminating these areas of abnormal conduction that actually turned out to cause the ST segment elevation. Now, be careful, because the people are doing other experimentation in other countries, And here you have, for instance, a paper about endocardial ablation in Brugada syndrome, basically showing the same properties of abnormal electrograms, but now endocardially in the outflow tract. And they have shown, like also Papone has shown, that actually there is a correlation between the area of abnormality and the ST segment elevation. The larger the area, the more the ST segment elevation, and they show also that they can normalize the electrocardiogram. At our center, we are performing now hybrid ablation, thoracoscopic. You see this mapping device that we use in the outflow tract of the right ventricle. And here I show you some very preliminary data. This is a short-term follow-up of a little bit more of 2 years on 36 individuals, only 36, that had this epicardial hybrid ablation. And you see that actually, indeed, sometimes you still will have some recurrences in secondary prevention people, but actually in the low risk and high risk that were ablated, this is going relatively well. Last part, I said to you, this is not a cardiomyopathy, this is an electrical problem of the outflow tract. Well, this is also coming from Argentina, and actually, Dr. Ortega and co-workers, what they do is they use the Synchromax, which is a non-invasive method of looking at asynchrony, and they show that in Brugada syndrome, before you do anything, here you have a typical Brugada syndrome, you will measure asynchrony, which is shown here. I'm not going to go into the details, but if you now go and pace the right ventricular outflow tract pacing, you eliminate this asynchrony in Brugada syndrome. Not only that, they have now 6 patients, one of them with already a follow-up of 3 years, a young lady with electrical storms that has never shown anymore any ventricular arrhythmia. Preliminary data, but I think from the mechanistic point of view, interesting, because it shows that this is an electrical problem of the outflow tract from my point of view, and not a cardiomyopathy. Anything we will do in the future, and this is my last slide, we'll have to consider this. What I'm showing you here, I'm showing you 30 patients with Brugada syndrome with a defibrillator that we took out at random from our database at random. And you see that there are only 29 because data from one were not reliable, so 29. And I just want to show you here, this is a follow-up up to 24 years. This is not 24 months, 24 years. And you see the first event, which was cardiac arrest in these individuals, they receive an ICD, and the black dot is the first event, the second event, after implantation of the ICD. I'm going to pick up 2 patients for you. Look at this individual, number 2, who had a cardiac arrest, received an ICD. After a few months, had a shock of the ICD because of ventricular fibrillation. And now, 23 years later, and he's not on drugs, and he did not have any ablation or anything, the patient is alive and never had a recurrence. Or look at this individual here who had a cardiac arrest. First defibrillator, never used. Second defibrillator, never used. And only after 14 years, he used for the first time his defibrillator number 3. So anything that you hear about treatment of Brugada syndrome, we need, like in cancer research, to follow all our patients until all of them die before making any conclusion. And we cannot say with 6 months follow-up that a new drug or something else that the disease is effective. We need very, very long-term follow-up. What can we do at present, at least in our center? We know more and more mutations. I just show you here on a slide of 2015. At our center, we are allowed to do pre-implant genetic diagnosis, and I know that this might be controversial for some people in the audience, both from the scientific and others from the moral point of view, but this is possible in our center, and we offer that. And here I show you a family with a father with Brugada syndrome, resuscitated from sudden death with a defibrillator. I show you with, of course, with permission of the family. You see that we went for in vitro fertilization, 8 eggs were fertilized, 6 were biopsied, 5 were affected, 1 was unaffected, and actually this was transferred, and this beautiful little girl was born without the mutation in the sodium channel. She has a negative Ashmalin test, has never had any symptom, and I hope that just by taking out one little piece of this abnormal genetic code, that is sufficient to prevent the syndrome. I don't know whether we have prevented completely Brugada syndrome, but at least we want to prevent the manifestations. So I will conclude that the progress in the understanding of Brugada syndrome has been very strong and steady, but as you have seen, there are many gaps still in our knowledge and the future that we need still to study. This is not a single disease. Think of the long QT syndrome. Now we have type 1, type 2, type 3, etc. In Brugada syndrome is exactly the same. There is one manifestation, which is the ECG, but there are many diseases that give rise to this electrocardiogram. The ultimate progress in Brugada syndrome will come from understanding the substrate, the genetics, but also the pathophysiology of this substrate in the right ventricular outflow. And for me, the present priorities nowadays as clinician, as physician, not as only researcher in genetics or whatever you want, is the identification of these individuals as soon as possible. Think of Brugada syndrome, because 50% of those who die suddenly never had any previous symptom. Don't think that you will have a warning with syncope. This is not true. And once you identify this patient, use the risk stratification tree actually to decide whether you treat or not the patient with the present methods that we have, which are limited, but still they are able to protect the majority of patients with Brugada syndrome. Thank you for your attention.
Thank you, Dr. Brugada. You presented the overview of the Brugada syndrome and the future direction of Brugada syndrome very beautifully. Again, thank you, Professor Brugada. We move to the next session. Dr. Rafael Rasso from Israel. He's talking about the early reproduction syndrome. Rafael.
Good morning, ladies and gentlemen, colleagues. I would like to thank Dr. Nademane for the great and for the very pleasant invitation to be here today. It's the fourth time that I'm at the PHRS, and it's a great honor also to give a talk in between two masters of channelopathies as Dr. Brugada and Dr. Nademane. My talk is about the malignant form of early repolarization, and as Dr. Brugada has done, I will talk about what we know so far about the disease, and then I would talk about the new findings that are coming from the most recent papers just published in the literature. The malignant form of early repolarization was described 11 years ago after a series of case reports, mainly from Japan, showing that there might be a variant of idiopathic ventricular fibrillation, which is characterized by the presence of J waves in the surface ECG, J waves that are increasing in amplitude just prior to the initiation of ventricular fibrillation. And these case reports that led to two large retrospective case control studies, the paper by Michel Seguer on 206 patients from several centers in France, and our paper in JAC on our cohort of patients with idiopathic ventricular fibrillation, 45 patients. And both papers have shown that indeed there is a variant of idiopathic ventricular fibrillation with early repolarization that we define as the malignant form of early repolarization. This paper has fueled a lot of interest in the field, and indeed, as you can see, the number of publications on early repolarization and J-wave since then has been increasing exponentially. And even in 2019, there have been so far almost 40 papers with early repolarization in the title. This finding has created important questions. The first one, what is the true incidence of the malignant form of early repolarization, considering that J-waves expression of the benign form of early repolarization are extremely common in the general population, can be as high as 20%, and even more than 40 or 50% in young individuals, particularly in male, in athletes, where it can be as high as 40% in Afro-American. In 2012, we made this estimation of the risk of a person with J-waves to have a cardiac arrest, And we find out that the risk would be in the order of 11 in 100,000 individuals. If we include other findings on the ECG that have been shown afterwards to be more frequently present in patients with a malignant form of early repolarization, we still go to very low numbers of 1 in 2,000 to 1 in 3,000. And the second question is, what is the meaning of early repolarization in the general population? And I can say that after several studies so far, the idea is that the presence of early repolarization in the general population has no relationship to the risk of sudden cardiac death, or at least the signal is very, very small. Nevertheless, if we look at one of the papers on the Finnish population, the paper by Tikkanen in 2009, he actually has found that J waves of 2 or more millimeters in the infralateral leads was associated with an increased risk of cardiac and arrhythmic death. But as you see, the risk appeared at the age of 64, which is clearly not the age that you expect for a patient with the malignant idiopathic form of early repolarization. But in this case, the idea is that the J waves are actually the marker of an arrhythmogenic substrate, which can become evident in the presence of other conditions, in particular coronary artery disease, which is the most important reason for morbidity and mortality by the age of 60 and more. And indeed, the same group have shown a few years later the presence of J waves, in this case with a flat ST segment following the J wave, increased the risk of primary ventricular fibrillation during acute myocardial infarction. Dr. Demidova, in her work on the pig model of acute myocardial infarction, has found that ligation of the LAD results in widening of the QRS and the appearance of J waves that are preceding the initiation of ventricular fibrillation. Now, we have learned to look at the ECG carefully, and we have found that there are features that increase the risk of arrhythmias. J waves of more than 2 millimeters increase the risk. We have looked at the ST segment following the J wave and found that the flat, horizontal, and sometimes descending ST segment is more frequently seen in patients with the malignant form of early repolarization compared to controls. We have learned that, of course, diffuse high voltage J wave increase the risk of arrhythmia. We've learned from the SGS group that small T wave, less than 10% of amplitude compared to the R wave in the lateral lead, is 8 times more frequent in patients with a malignant form of early repolarization compared to healthy controls. We have looked also at the behavior of the J waves during changes in the heart rate, and this is a paper from Aizawa and Esseguer showing that there is a post-dependency J wave augmentation, which is seen only in patients with the malignant form of early repolarization. You can appreciate the increase in the J wave amplitude just after the pause, with the J wave afterwards that becomes even smaller than the baseline and then returns to baseline. We have also learned that the behavior of the J wave in patients with the malignant form of early repolarization during atrial pacing is different than controls. As you can see, again, in this paper from Aizawa, rapid atrial pacing reduced the amplitude of the J waves in the malignant form of early repolarization, while in healthy controls, the J wave amplitude seems to increase. The SGS group have shown us that there is no role for program stimulation in J waves in the malignant form of early repolarization. Regarding the family history, the data are not consistent. We don't have any experience of family history in our group of patients, but Michel Esseguer and Dr. Abel found a relationship with history of sudden cardiac death in the family in this patient. And indeed, in this paper published in JACC in 2011, the prevalence of early repolarization in relatives of family history of sudden cardiac death seem to be higher compared to healthy controls. And the more recent data coming from the CASPER registry have shown that the prevalence of early repolarization in survival of cardiac arrest can be as high as 35%, and in their first-degree relatives of 15%. And the first-degree relatives with a higher prevalence of JWES would be the one who have family history of sudden cardiac death related to the malignant form of early repolarization, followed by family history of sudden cardiac death in patients with the early repolarization, but other reasons for cardiac arrest, and the lowest in the first-degree relative of patients with cardiac arrest but no early repolarization, the surface ECG. If we put together all the risk factors for cardiac arrest in this subgroup of patients, we go from the horizontal ST segment to the increased J-wave amplitude, more widespread J-wave distribution. Importantly, the association, as Dr. Brugada has shown before, between the Brugada syndrome, short QT, fragmented QRS, and the early repolarization. This has been shown by Kawata, for instance, in this paper, with a combination of Brugada and J-Wiz in the inferolateral lead, and the presence of Brugada pattern and persistent early repolarization is associated with a very important risk for events during follow-up. And again, the presence of fragmented QRS along with early repolarization increase substantially the risk of cardiac arrest during follow-up. The family history, as I said, is an important risk factor, but the highest risk is for those patients who show on their alters the presence of short couple PVCs, and indeed this is the pathognomonic sign of the arrhythmia in the malignant form of early repolarization. These short couple PVCs originating most probably from the Purkinje fibers that induce polymorphic ventricular tachycardia degenerating into ventricular fibrillation. The pathogenesis of the early repolarization is being considered at the beginning as a result only of repolarization abnormality. This paper comes from the work of Chalan, Salevich, and Yan on the wedge preparation, showing that a voltage gradient due to different duration action potential between the epicardium and the endocardium is responsible for the appearance of the J-waves and the surface ECG. And when this voltage gradient reaches a certain threshold, we can actually start arrhythmia by a mechanism of phase 2 reentry between layers of the myocardium. The J-wave syndrome include acquired disorder as the Osborne wave during hypothermia, the J-wave that you can see in patients with acute myocardial infarction, the Brugada syndrome inherited disorder, and the idiopathic form, which is the malignant form of early repolarization. The repolarization theory has been confirmed by papers using the Cardio Insight system or the Yoram-Rudy system during its development. And this paper by Ghosh shows in dark blue these areas of very short repolarization in the right ventricle, which are contiguous to area in red with much longer repolarization. Actually, the presence of contiguous area with short and long repolarization can be the substrate for the initiation of ventricular arrhythmias. Another paper by Zhang has confirmed the same finding. Again, compared to the healthy control, you can appreciate that in patients with a malignant form of early repolarization, we have these areas in dark blue with very short repolarization, in particular in this case, in the inferior portion of both ventricles. And I'm going now to the very important paper that's just been published. The first one is, again, a collaboration of the work between Dr. Nademane and Michel Seguer, based on an abstract presented to the HRS last year. And they took 38 patients with inferolateral J-waves, and these patients, they had high-dense unipolar and bipolar endocardial and epicardial mapping. And the authors have found that in 24% of these patients, there were indeed signs of depolarization abnormalities, while 76% and only early repolarization. And you can appreciate that in patient with delayed repolarization, in the bipolar mapping of the epicardium, the right ventricle, there were areas of low voltage associated with fractionated electrograms extending and coincident with the J-waves and extending even after the QRS as a late potential, compared to patient with the only repolarization defect in which there are no electrograms whatsoever during and after the J wave. This is another example of a patient with depolarization abnormality. You can appreciate the presence of low voltage in the inferior portion of the right ventricle, which consists also with the area of latest activation, compared to a patient with normal repolarization abnormality, no substrate, no low voltage area, no late activation. You can appreciate these bipolar and unipolar fractionated electrograms that are on time with the J wave during the repolarization window, which are not appearing in a patient with repolarization abnormality. Using the cardio insight, they also look at the drivers for ventricular fibrillation, and they found that the drivers in patients with substrate are actually in the same area where you get the low voltage. So in this case, in the right ventricle, in the inferior portion of the right ventricle, while in those with early repolarization only, no substrate, the drivers are located mostly in the inferior portion of both ventricle and mostly at the area of the septum. The same group has just published this great paper in Circulation on a large number of patients with malignant form of early repolarization. Again, the patient underwent endocardia, epicardia, unipolar, bipolar mapping, and they could define two groups of patients. The first one, 40 patients with depolarization abnormalities. 33 of these patients had also a Brugada pattern on ECG. 7 had only the malignant form of early repolarization. These patients were all males, and the mean age was 39, compared to group 2, which is represented by 12 patients with only repolarization abnormalities. In this case, 64% of these patients were male, and the mean age is younger, 29 years old. This is an example of a patient with a malignant form of early repolarization, no Brugada pattern on ECG. You can appreciate again on the bipolar mapping the area of abnormal substrate in the inferior portion of the right ventricle, with this fractionated electrogram standing up to 160 milliseconds. Looking at the drivers of the ventricular fibrillation, the authors have found that the drivers in patients with a substrate are all located in the right ventricle, in particular in the inferior portion of the right ventricle, while in the group with only repolarization abnormalities, the drivers are located mainly in the inferior portion of both ventricles and mainly at the area of the septum close to the Purkinje system. This is another example of a patient in the group with a substrate, again, low voltage area in the inferior lateral portion of the right ventricle, which is consistent with the same area of the cardio inset where most of the drives, the rotational drives of ventricular fibrillation are located, along with these fractionated electrograms. 43 of the patient underwent ablation. The results of ablation I've shown in the graph, and you can see after the first ablation, the success rate was 67%. After multiple ablations, the success rate went up to 91%, freedom from ventricular fibrillation, and a mean follow-up of 31 months. And as has been shown for the ablation in Brugada, the ablation of this substrate results also in the disappearance of the J waves and the surface ECG. This is a patient with both Brugada pattern and early repolarization in the inferolateral lead. You can appreciate that adrenaline test after the ablation showed disappearance of both patterns and also the disappearance of all these fractionated electrograms in the area of substrate treated with ablation. In those patients with only repolarization abnormality, no substrate, the arrhythmia can be treated by targeting the Purkinje PVCs initiating the polymorphic ventricular tachycardia, and this has been done successfully in this group of patients. Another paper that is very interesting, I think, which shows what is the heterogeneity of the disorder, is this paper that comes from Mel Scheinman on 10 patients that he collected in San Francisco in 10 years. And it shows that in 3 out of 10 of these patients, the ventricular arrhythmia that were recorded were not polymorphic ventricular tachycardia, but monomorphic ventricular tachycardia, by the way, initiating with quite late couple PVC. And this is one of the patient. The patient has this monomorphic ventricular tachycardia, which starts with the late couple PVCs. The patient was taken for an ablation. He had endocardia and epicardia mapping. The authors found in the infralateral portion of the left ventricle, not of the right ventricle, the same signals that Dr. Narimane has found in the inferior portion of the right ventricle. By the way, this late component becomes early during the spontaneous PVCs. The patient went into monomorphic ventricular tachycardia with the mid-diastolic potential in this area of substrate in the lateral left ventricle, and it was successfully ablated. The same group has treated patient by targeting also PVCs, initiating the polymorphic ventricular tachycardia, and in this case, for instance, the PVCs were successfully mapped and ablated in the epicardium of the lateral left ventricle, not of the right ventricle. I would like to conclude by showing this slide that quinidine can correct and get the disappearance on the J-width on the surface ECG. And in our experience, in our cohort of patients, the quinidine was extremely effective in preventing ventricular events during follow-up. But it has to be reminded that in the Nanemanis paper, all patients with substrate with these low areas of low voltage in the right ventricle were failure of the treatment with quinidine, which underscored the idea that a subgroup of patients in the malignant form of early repolarization, some of these patients, those with a substrate, probably should be directed toward an ablation as a first-line therapy. Thank you very much for your attention.
Thank you, Dr. Russell. You presented very nice future direction of the J-wave syndrome. We appreciate your speech. Thank you. So we move to the last speaker, Dr. Kanrung Nadmani from Thailand. He's talking about the outcomes of catheter ablation for treatment symptomatic Brugada syndrome.
Thank you very much, Mr. Chairman, ladies and gentlemen. Don't worry, my talk is very brief, and you will make it for the closing ceremony. This is my disclosure slide and funding sources. For the past couple of years, we have been collecting the data with the worldwide register. As you can see here, in the geography class, the teacher always asks me all the time that what are these facts are. This is a participating center. We will have a quiz in the audience to which country have been participating. But the Bravo registry is the aim of the study is to report a worldwide Brugada ablation of ventricular fibrillation substrate, and we keep it ongoing to determine the long-term outcome of catheter ablation in Brugada syndrome. As you know, that Pedro just presented to you that you need a long-term follow-up to determine and then whether or not your treatment is good. The study population is basically symptomatic Brugada syndrome patient who underwent substrate ablation for recurrent ICD discharge due to ventricular fibrillation. All the tertiary center for catheter ablation of complex arrhythmia. This is from 3 continents, Asia, Europe, and North America. We excluded any patient who declined for the follow-up or lost to the follow-up. This is the list of the participating center. This is the hardcore data. Up to this, this time we have 154 patients of Bucata syndrome with ICD. Median age is 38 and one female. 135 cardiac arrest survivor and 19 syncope. Very serious group of patients. The 146 underwent the percutaneous epicardial ablation, and 8 underwent open thoracotomy ablation because the access percutaneously to the epicardium was not possible. So we performed the comprehensive electrophysiologic study and program stimulation like a standard protocol. And then we do the protocol mandate the endo and epicardial electroanatomical mapping of both ventricles at baseline and after sodium channel blockade. The group from Taipei used warm saline during the mapping to help unmask some of the substrate. And then they proceed to do the ablation. The target, the endpoint of the ablation is to eliminate all the abnormal areas that record fractionated signal and low voltage lead potential. And of the 154 symptomatic patients, Bucata syndrome, the 124 had only Bucata ECG pattern. 30 had a combined Bucata and early repolarization pattern. After the first ablation, 102 patients had a normalized EKG. This group had an excellent prognosis. So far, had no VF recurrences. With I will show you the slide again. I forgot now the mean age is several years. Those groups that have still remain have the ECG pattern of Bucata pattern, 36% would have recurrences. This actually means that all these patients underwent a repeat ablation. The 30 Bucata syndrome and early depolarization syndrome combined, 21, even though the Bucata EKG was normalized, they still have recurrence of 18%. This is because of combined syndrome. This is not an easy group to do. And you have seen our data from Dr. Ross's presentation that the first ablation success of this patient at the beginning is 61%, but later, and with repeat ablation is 91%. But now we learn more. We believe that the success rate in this group from now on would be better than 61%. Or more than 82%. The patient who had either Bucata syndrome pattern remained or early repolarization pattern remained have a very high recurrence rate of 55%. And if you're looking at the pre-ablation, many of these patients had the multiple shock, over 10 shocks, and 14% of the patients had no shock when they underwent the ablation. This is only data from 151 patients because 3 patients refused ICD that underwent the ablation. After first ablation, 83% had been free of the recurrent EVF with a mean follow-up of 39 months. And after last ablation is 96%. Very good result. So in conclusion, patients with a pure Bucata syndrome without concomitant ER whose EKG was normalized after catheter ablation, especially after sodium channel blockade, especially after asmalene, perhaps I should say, I'm sorry, don't yell at me, I should say may possibly be treated without ICD. But that needs to be further investigated. We are collecting the data of that so that maybe we can do a randomized trial in the future. So this is a randomized trial that we right now currently being done. The BRAVE study decided that we want to compare the ablation and the control. And then we want the idea is that if we want to find out if the data that from the registry data from Bravo registry data that show no Brugada marker correlate with no VF is correct or not. But this is going to be a prospective study, and we will compare with the control. This is the randomized trial. So far, we enroll about 22 patients. But when we're talking about curing Brugada syndrome, besides from what Pedro highlighted, the complexity of the syndrome, you have to also ask this question. Do we truly understand the substrate and the underlying electrophysiologic mechanism? Can substrate change over time? The second, how does one know that the ablation that you have done create a durable and permanent lesion? But if it does, can some of the ablation sites become the arrhythmogenic site later on and cause ventricular tachycardia? Those have to be answered for the future study and follow-up. And this is my last slide. Thank you very much.
Thank you, Dr. Nadmani. The time is just the end of the session. Again, thank you for everyone to join this symposium. Thank you. We close this session.